Good afternoon, everyone. If you could please take your seats and we'll proceed with the next part of our program. As you know, today is World AIDS Day, and we're very pleased to have with us here today the director of the New York office of the Joint UN Program on HIV/AIDS, Simon Bland. Mr. Bland, please,
Great,
the floor is yours.
Good afternoon, everybody. It's great to be here. December the 1st, World AIDS Day. This is the 30th World AIDS Day since the first held in 1988. And it's a day where we reflect, remember, recommit and resolve to deliver on the ambitions that we've set ourselves. And when we think back over the course of the last 35 years or so, of HIV infection and AIDS as a modern-day plague and the toll it has taken. It is a remarkable story of progress, but a story of unfinished progress, where the gains we've made are incomplete, fragile, and indeed reversible. So I just want to say a few words about where we've come from and where we are today. During the late 80s and early 90s, when the world was discovering the enormity of the challenge ahead in tackling what became then known as HIV and AIDS, there was really nothing in place for humanity to get ahead of this epidemic. A number of institutional innovations, the formation of my own organization, UNAIDS, subsequently the formation of the Global Fund to fight AIDS, tuberculosis and malaria, the United States announcement of the President's emergency plan for AIDS relief, really showed how seriously the world was taking the challenge of tackling HIV and AIDS. And while we've lost almost 36 million people to HIV/AIDS over that period, and today we have 37 million people living with HIV and AIDS, it could have been much worse. When I was living in Africa in the early 90s, to be infected with HIV was an imminent death sentence. Now, it isn't an imminent death sentence if you're lucky enough to have access to the antiretroviral treatments that you need. And if you do have access to that treatment, you live a life as long as someone living without HIV. And that's quite remarkable. Today, we calculate around 21 million people of the 37 million people living with HIV have access to that treatment. So that's great progress. And if you think, we just came from an event where we talked a little bit about South Africa. In 2000, 90 people were accessing treatment. Today, 4.1 million people are accessing treatment. So when you look at that trajectory, it's quite astonishing. And yet there are still around 17 million people that need treatment that don't get it. So the job is far from finished, is incomplete, and needs a redoubling of our efforts to get there. Now, each World AIDS Day, we have a theme where we specifically shine a spotlight on a particular set of issues. This year, we have a publication talking about the right to health. So it's not only the biomedical approach to tackling the disease, but it's also giving people the right to access and utilize the services and information and policies and legislation they need to stay healthy, including tackling and responding to and preventing HIV and AIDS. It talks about the accessibility of services, the availability of services, the acceptability of those services, and the quality of those services. Equally, today, my boss, Michel Sidibe, is in Canada, commemorating World AIDS Day there, and has released a second report. And one of the stories we have of the AIDS response is, as we've been learning over the last 35 years, we continue to have more and more relevant and timely information to better understand the nature of the epidemics in the contexts in which they sit. So new evidence from 16 countries is showing the particular role and characteristics that men and boys face in the HIV epidemic. So we know that the vast majority of the burden of HIV and AIDS falls on women and girls. But we now know the intricate and important relationships around infections in men and boys. So we know that, for example, men are far less likely to seek health-seeking services than women. We know men are far less likely to get an HIV test. We know that men are far less likely to access treatment, to adhere to treatment and stick to that treatment. We know that cultural norms, damaging masculine behaviors can also increase their risk by not seeking the advice for prevention and treatment that they need, but also make them more dangerous in terms of transmitting the disease to others. So we've also released a report today called Blind Spot that talks in those countries about the specific challenges of tackling men and boys. The final thing I want to say is, while we talk about HIV and AIDS, it isn't one epidemic. It's countless epidemics that are very contextual based on the situation, the location, the population, the policy, political and legislative environment in which it fits. And therefore our response, as we learn more and more each year, as the evidence and data that we get each year continue to illustrate the nuances of the disease, we're able to better tailor our responses to tackling that. The final thing I'd say is that part of our challenge of making the great progress we've made is that people think the job is done. Our slogan, if you like, if we have a slogan, is AIDS isn't over, but it can be. And as part of the SDGs, we commit to ending the AIDS epidemic as a global public health threat by 2030, and we're asked, can we get there? Well, yes, we can get there, but, you know, it's a little bit passé to say business as usual doesn't work. Well, business as usual won't work, but we have innovations every year. We have new treatments, less toxic, lower doses, lower cost, point-of-care diagnostics. So there are new innovations all the time that move us towards our goal. And we continue to support the investment in research and development for vaccine and possible cure. So our message is there is great progress. We cannot stop now. AIDS isn't over, but it can be. Complacency kills. We need everybody to redouble their efforts in order to get to the end point of ending AIDS as a public health threat by 2030. Thank you.
Thanks very much. I'll open up the floor for questions. If you can identify yourself to our speaker as well. Luke.
Yeah, Luke Vargas, Talk Media News. I have a pair of questions. We'll see if I take them in order or we skip around. But the first one, I've been reading this child AIDS statistics that you put out today.
The UNICEF report.
Right,
I think, yeah.
right. And I was pretty shocked to see, if I'm looking at the numbers correctly, that just 43% of children with HIV are getting antiretrovirals. Could you just comment on that? That seems like a really surprisingly dire figure.
Sure. So UNICEF have released a report today, and it's a good report. And when I talk about HIV being multiple epidemics, and while one can see some great trajectories in some place, there are some challenges. And I talked blind spot. So we know, for example, there are challenges at the macro level in North Africa, Central Asia, Eastern Europe, where the trajectory is pretty bad. But we also know that adolescents and children have been somewhat left behind. Now, that's not to mask progress that's been made. 2 million child deaths have been averted, 1.6 million since 2000. The number of deaths has halved over the last 6 years. The number of infections has reduced drastically. But yes, you're right, still only 1 in 3 children, essentially, that needs a treatment is getting the treatment. And so we need to recommit our efforts there. We need to ensure we're investing. We need to ensure that the health systems are responding to the particular challenges of adolescents and children.
Good afternoon. My question is, what's in the Middle East, the number of the AIDS of the people over there?
Thank you. I'm going to look for the statistic.
Like Arabic countries and to the Far East.
So I'm going to give you Middle East and North Africa. In 2016, there were 230,000 people living with HIV in the Middle East and North Africa.
That's a very good number. It's not that much.
Well, it's a lot if you're one of them. So it's, but the trajectory is not good. The trajectory is the number of infections is increasing. Yeah.
Thanks.
Yeah.
Yes, Abdul Hamid Sayam from the Arabic daily Al Quds Al Arabi, and I'm also interested to know how is the situation in China. Do you have access to go there and do the investigation, get the statistics and correct numbers of the AIDS HIV in China? Thank you.
So we have a good partnership with China. My executive director has been many times. He knows China well, and we collaborate quite closely, not only in their national efforts, but also in how they can help internationally. I don't have the China-specific statistics with me, but in my previous role where I was chairing the Global Fund, we worked with China there as well. And that was at a time where, you know, China doesn't take that international concessional finance anymore. It did that pivot to funding its own programs. If you want the specific China statistics, I can certainly get them for you.
Hi, me from Xinhua News Agency. It's a follow-up question to this that gentleman about the cooperation between different UN agencies, WHO, UNICEF. Is there a kind of mechanics between you?
Yes. So if you just think about what the world adopted in September 2015 with the Sustainable Development Goals, people said, well, in order to deliver on this integrated, universal, integrated agenda, you're going to need to think differently, work differently, and organize differently. Well, back in the mid-90s, when people were thinking about how the heck do we get ahead of this HIV/AIDS plague, they said we need to think differently, work differently, and organize differently, and they created UNAIDS. UNAIDS is the joint United Nations program for HIV and AIDS, and it's joint because members of UNAIDS are WHO and UNICEF and UN Women and UNDP and the ILO and the World Bank and WFP, and I'm sure we have 11 co-sponsors that work together, and we try and use our collective comparative advantage. So, the argument was you can't just take a medical approach to tackling AIDS. You need multiple stakeholders working across a whole broad range of sectors that are addressing issues such as rights, employment, a whole range of issues. So that was in the very founding part of our organization. And one additional part to that was not only collaboration across the UN, but also collaboration with civil society. And I think we are still, to this day, the only part of the UN that have civil society actively sitting on our governing board. So that collaboration is clearly part of our DNA.
Hi, my name is Ibtisam Azim from Al Arab Al Jadid newspaper, a pan-Arab newspaper. I have two questions. The first one is regarding the US. In the US, we have the issue of health insurance and the problems of health insurance. To which extent this affects people who are infected, and if there is alternatives or possibilities for them to get help. And the other question regarding back to the Middle East and the Arab world specifically, could you point out examples or maybe countries and NGOs who are cooperating, or other countries who are where you have more difficulties to have statistics or to get to people and to work there? Thank you.
Sure, thanks. So let me do my best on those. So look, across the globe, there are very many different health systems in terms of how they're structured, how they're organized, and how they're financed. Some are predominantly public, some are predominantly private, some are a mix. Some are funded through taxation-based systems, some are paid through insurance-based systems. Some are single-payer, some are multi-payer. So there's a variety of systems. So I'm not going to talk on a specific one. But any system that is leaving people behind, where people can't access their right to health, can't access the treatment and care that they need, is a challenge for us. And that's what we're trying to shine a spotlight on with our rights. We've just heard, what New York State and New York City is doing in terms of committing to the agenda that we've set, ending AIDS by 2030. New York State's agenda is ending AIDS by, I think, 2025, 5 years earlier than ours. So they have a commitment to doing that. And part of that is around, yes, providing more resources to it, but also just learning the lessons of what is precluding people from accessing the services they need. The final thing I'd say about the US is not only domestically what they're doing, but the US has been a world leader in helping tackle globally HIV and AIDS. The establishment of the President's Emergency Plan for AIDS relief, the support they give bilaterally, the support they give to the Global Fund to fight AIDS, tuberculosis, and malaria, the support they give to us and to others, has really helped shift the needle, I think, in terms of the trajectory of fighting the disease. We ask on the rest of the world to step up and help America continue to do the right thing and to maintain those programs and, in fact, hopefully increase those programs. But the rest of the world has also got to do that. Finally, I'd say, in response to that part of the question, it was last year, for the first time ever, that the majority of the resources funding HIV and programs were domestic. Not aid, not international. And that's taken a long time to get there. But long may that trajectory continue, and we need to further increase domestic investments. That's domestic public investments, but also domestic private investments. South Africa, I think 97% of its program is domestically funded. We talked about China earlier. It is domestically funded. It is not international. Now, in terms of those countries where we struggle to get information, I think I'll need to come back to you with that. I mean, one of the things I would say is that in terms of the time series of data, that we have for HIV and AIDS is second to none, and that's really been dependent on the international collaboration and cooperation of all member states to provide that intelligence and that data that we then compile, collate, and publish. Now, sometimes there are disagreements. The data that we have, the calculus that we do, doesn't always square, with the national governments, but we find ways of reconciling that. But we have an incredible data set, and the UNICEF report that you referred to, talking about children, is taking the data sets that we've helped and taken from countries and compiling those and analysing those and putting those out. And then in terms of NGOs, some environments, NGOs have an environment in which they, can work very openly and clearly, and others it's more difficult. And some of the work we do, of course, is tough and sensitive. If we're talking about sexual and reproductive health and rights, in some countries that becomes challenging and difficult. If we're talking about keeping girls in school and dealing with comprehensive sexuality education, that can be sensitive and difficult. If we're talking about meeting the needs of those left behind, key vulnerable populations, be that injecting drug users, gay men or other men who have sex with men, sex workers, etc., we know there are sensitivities there. But we support and help support the vibrant role that civil society can play and moving services closer to the community so people can actually get the services in a way that they feel they are not discriminated against, there is no stigma and discrimination, and hopefully where they're not criminalized.
Sure. Matthew Lee, Inner City Press. I wanted to, just on what you were saying about discrimination, it was said earlier in the briefing that the Deputy Secretary General is going to Egypt to meet with officials there, and I'm just wondering if there's been a lot of coverage recently about various forms of discrimination on the issues that you mentioned. Are you aware that will she be raising it? Is it something that UNAIDS has raised there? And I also want to ask you about needle exchange. It seems like I assume that UNAIDS is in favor of it as a way of bringing down AIDS, but I think that that International Narcotics Control Board, they've been in here sometimes, and they seem to take a different view. They don't come outright and say it's bad, but they don't praise countries for implementing it. And it seems, are there tensions in the UN system in terms of an issue like needle exchange, and how should those tensions be resolved if they exist?
So if it was easy, it would be done. Yeah, you're right. I mean, there are inherent tensions, and I'll come to those in a second. The DSG's visit to Egypt, we haven't spoken directly with her. I know we talked to her quite regularly about our agenda and a broader health agenda and indeed SDG agenda, and leaving no one behind and ensuring everyone gets the rights that they deserve. So my hope is that she will. Whether she does it openly, whether she does it privately, and how she does it will be for the DSG. I'll make sure that she gets a message from us that this World AIDS Day, tackling stigma and discrimination, decriminalising key populations, and allowing people to exercise their right to get the best attainable health they can is important to all of us, and I know she stands firmly behind that. Needle exchange and harm reduction, we believe strongly there is global evidence that suggests these are important programs that have an impact, reduce the harm and the risks of transmitting the disease, but you do come up then against the battles of, and you see it here with the opioid crisis. Is drug dependency a crime? Is drug dependency a sickness, ill health? How do you respond to that, and how do you tackle that? We will continue to advocate that harm reduction works, that opioid substitution therapy works, that decriminalizing and providing people a safe place to receive the services, information, advice and care that they need is not only good for them individually, but is good on a population level in terms of reducing transmission of a global public health threat.
You had a hand up? Excuse me. I guess you have. Yes, you had a question? Yeah. Oh, okay. Okay, then we'll go for round two. Then Luke, and then Abdulhamid.
Great. Going back to the children numbers, I know that's UNICEF, but it does get into some UNAIDS targets as well. The 2015 target was missed, and the report this week suggests 2020 is out of reach too. Could you cue us in on any sort of internal timeline at UNAIDS about when we now think that goal could be achievable, or is that something we're going to have to wait to see codified into another official
So I'm going to be
target?
very reluctant to say, well, okay, let's shunt it back 2 years. It's funny, we did a TB meeting a couple of days ago where people said, at the same level of progress, we don't get to the TB targets until 2156 or something. Now, what the UNICEF report also says is that while we may not be on track, and we're not on track for every target that we set in HIV, the AIDS response has been quite remarkable in actually being able to catch up and finding ways to catch up. So at times when we've missed targets, we set a target 3 by 5, 3 million people on treatment by 2005. We missed that target. We then set a target of 15 million people by 2015 that people said you couldn't, address. We overshot the 15 by 15. So we must continue to set high ambition. We can now, and I don't think the UNICEF is laying a date on this. It's just saying, with the present trajectory and the same sort of work, we don't get there. What I'm saying is that no 2 years should be alike. The work we do next year will be subtly different from the work we do this year, because we have new evidence, we have new tools, we have new technologies, we have new innovations, and we're learning lessons of what's more effective. So we're going to keep pushing for the 2020 milestone targets for all populations, but we're going to have increasingly real-time data that lets us know where we're off course, and hopefully how we can tailor and course correct in a way that gives us the maximum chance of hitting the targets that we've set ourselves.
Can I just ask, it sounds like you're sort of suggesting that these zero infections targets might be a little bit tricky for UNAIDS, because they might imply to the public that progress is just not being made because they're so ambitious. Is the idea to maybe focus now on more quantitative targets as opposed to qualitative?
Well, we certainly want quantitative targets, but quantitative targets on their own without quality don't work. Now, and I think, where I get excited within the SDGs and our part of the SDGs is we're pretty clear what success looks like. In 2020, we know that success for us is less than 500,000 new infections and less than 500,000 deaths and zero stigma and discrimination. Because we can't say 20% stigma and discrimination is okay, right? You have to set that goal. Stigma and discrimination should not exist. We need to try and root it out of the systems. But the quantifiable targets in terms of infections and mortality are there, and then reducing those to under 200,000 by 2030 is the narrative, and that's what we're shooting for. Yes, we have. Our ambition is a world where we have zero deaths, zero infections, zero AIDS, and zero HIV. Without a vaccine and a cure, that's difficult. Not the AIDS part, but the HIV part, because there are 37 million people. If we have a vaccine, if we have a cure, then the zeros become realistic. So that's that vision, if you like. Our mission right now is to have the trajectory within the 2020 milestones and the 2030 targets of the SDGs around infections and mortality.
I want to ask about the prices of medicine. In the early days, there was some competition between Western pharmaceutical companies with high prices, and India tried to put in the market some generic brands, and there were legal battle. How is the situation now? Are these medicines affordable by poor people?
So it's quite a remarkable journey. You're right, in those early days, once the discovery of the virus, once the discovery of AZT and other combination therapies were there, and the event we've just come from looked back on the history in this country of how people demanded, access, do something, we're dying. And so they created the tools, the pharmaceuticals, but they were costing $10,000 to $15,000 per patient per year. Okay, and the history of how activism, not only activism here, but activism globally, the stepping in of a number of Indian generic companies, Cipla at the beginning of that, really helped change that dynamic. So now we're at a point where, on average, a person, depending on where you are and how specifically you count it, it's less than $100 per patient per year. That's generally affordable everywhere. Now, medicines get better. We had a deal a few months ago with a drug called dolutegravir. Even more powerful, even better, lower dose, lower toxicity. We continue to work to drive the prices down. The Secretary General commissioned a high-level panel, an objective, independent, and diverse panel to look at the issues of intellectual property, patents, generics, discovery of new diseases, and affordability and access. So the story is not a bad one, but it's a microcosm of the broader story. It can't stop there. We need to continue to shape markets. We need to continue to have the discovery. We need to continue to have competition. And where the markets aren't quite doing that, we need to find ways in which we can intervene to ensure the markets give us what we need. A classic example is antimicrobial resistance. You know, where the bugs become resistant to the drugs, if we're not developing new drugs, then we lose the gains we've made. So we have to continue to stay on the front foot. But affordability now should not be the main challenge that stops people getting treatment. It is other things. Getting them to access the facilities and get tested. Still far too many people don't even know they're positive, so testing is a big part of that. And so we set out a framework called 90-90-90. By 2020, we want 90% of the people living with HIV to know that they have HIV. We want 90% of them to be accessing the treatment they need. And we want 90% of them to stay on that treatment, adhere to that treatment, because that suppresses their virus. And if their virus is suppressed, they have a life as long as someone living without HIV/AIDS. But also the chance of them transmitting that disease to anyone else is 97% reduced. So to all intents and purposes, they cannot infect someone else with HIV if they are sticking to their treatment and their virus is suppressed.
I'd like once more to thank our speaker, Simon Bland. Thanks
Thank
very,
you, guys.
very much. And have a good afternoon, everyone. And at 3 p.m. in this room, you will have the President of the Security Council for the month of December, Ambassador Besho of Japan.